Hey, good evening, everybody. I hope you can hear me okay.
We hear you fine.
Okay. The cases are usually the fun part. That's where we get to really work on the jigsaw puzzle and put the pieces back together. And we have such an expert panel that I thought I would share a few cases. Some are simple, maybe some are a little more complicated, but these are cases that I've seen either last week, this week, or within the past 2 weeks. So I tried to make it real. This is real life. Okay, I saw this kid November 4th, and this is for anybody on the panel, but I will call on people if people aren't ready to are moving forward, because I really want to hear from everybody. He's a year after Tommy John surgery, hit his 1 year anniversary. He's throwing off the mound and his elbow's perfect, but now his shoulder hurts. And this is during the rehab phase. He's just about to get competitive. And his exam, things are acting normal with biceps, labrum, internal impingement, dynamic labral shear. His scapula looks pretty good. I mean, we could always find some problems. Here's what I wanted to show you. This video last week, all the other exam features are normal, but look how weak his cuff is. Kevin, weigh in on this. What happens after Tommy John surgery with all of our great rehab that we have a rotator cuff that's weak? What happened?
Well, one is, I hate to say, but maybe the rehab wasn't so great. Maybe, you have to ask him, what were you doing a shoulder program? What were you doing with the shoulder program? A year out, he might have gotten deficient with his program a little bit, got a little complacent. The other thing is maybe he got too aggressive with certain exercise, and now he has pain inhibition in his shoulder, which is shutting down his rotator cuff in particular. So I'd ask him, what have you been doing? Are you over aggressive? By his body type there, he doesn't look like he's a big workout guy. So it could be just he's gotten a little sloppy. Also, obviously, I would talk to him about his mechanics. We did a study on this, as you know, Dr. Ahmad, where we had a pretty big N of UCLs, and we asked them specifically, have you ever had a problem with your shoulder during your course of rehab with their follow-up at 2 years and greater? And about 5% will experience some shoulder problems along the way. So, we can't neglect the shoulder.
I think you're right, Kevin. A big part of rehab is making sure nothing else breaks down during this process. And we talk about periodization because the rehab process is long, and some of these guys are throwing longer without a break than some of our non-injured competitive athletes who have built-in breaks. Some of these guys are rehabbing in the off season, and then they get into the regular season when they're recovered. So we could probably dial in some periodization and everything you mentioned about proper rehab, et cetera. So Eric, do you have anything to add to this? What's been your experience with guys who have been rehabbing TJ and getting shoulder issues? Is it common or uncommon?
I'd say super common. I think what you see a lot, particularly in this era of kids really selling out for velocity, is a lot of those athletes, they chase early arm speed in their delivery. And you look at the best, pitchers on the planet, they're all guys that, they don't chase that early motion. It kind of happens. You talk to them about when they throw their hardest. It's when they're relaxed, they let their arm whip through and they power late arm speed. So we talk a lot with our kids about you can't generate velocity until front foot strike. And when you try to, those same anterior shoulder forces that probably are creating some of his symptoms are the ones that early on created extra valgus stress. The other thing I would say to echo Kevin's point is, I mean, a year is a long time to overhaul a body. I mean, that looks like a young kid who's still got, puberty on his side. Like, you should see a pretty dramatic physique change, outside of those first 6 weeks or so. You can really get after it pretty good in the weight room and change your body. So when I see somebody walking in like that, it's probably a sign that there were a few boxes they didn't check along the way.
Well, let's keep going. We only have a few minutes, and those are all great points. I blocked out his face, but he's feeling pain. You could see it on his face when we're doing this. And Chris Camp, are you on? Are you able to? Can we hear you?
I am, yes.
All right, Chris Camp, who's team physician for Minnesota Twins, he's in the next session. Chris, would you inject this guy, or would you do a workup of some sort? What would you do in this situation?
Yeah,
He's a year from his TJ, and he's shutting it down because his shoulder hurts.
Yeah, I think this is, I mean, and that's a pretty profound amount of weakness, right? For somebody who's a, relatively high level athlete. So for me, this would sort of, I'd slam on the brakes here real quick. We got to figure out what's going on with his shoulder, because we're not going to be able to finish his rehab for his elbow until we address his shoulder. And we know everything is linked. So yeah, for me, this is going to be a pause. We got to figure out what's going on here. Diagnostic injections, maybe advanced imaging, those types of things.
I feel like the kid hasn't thrown that hard that he could have blown up his shoulder and ripped off his subscap or tore his capsule. And he's got a normal exam except for his rotator cuff. So no MRI, do an injection. He wants to get back for the spring, which is approaching. Just saw this kid last week. We do an injection. You can see his cuff there. We're infiltrating the subacromial space. And it is, if we can get this to play. Right, so we move him around a little bit. This is 10 seconds after the injection. 10 seconds.
And how was his pain response? Assume, did he have complete relief of pain?
You want to see the video again? Is that what you said?
No, I'm saying in addition to the strength, I'm assuming he had full strength, no pain.
He had great pain response. So, what I think happens is we have guys who are working on the margins with their shoulders. Their whole this is the whole concept of throwers. They're Ferraris, and during the whole rehab process, we have to make sure that we're not just focusing on one element of the race car, because any little tweak, malalignment could be an issue. And our job during rehab, where we all work together, is if they get off course, we want to get them right back on. And I gave him an injection, and I would consider that a bursal issue, which we don't talk a lot about. That's the reason why I wanted to bring this up on point, is that it's not always labrum, undersurface rotator cuff tear. Some guys just get bursitis and get tendonitis during a process. And yeah, maybe they did some extremely dynamic workouts. We talk about even during our functional assessment, these guys are burning their shoulders to death. Sometimes we just put them over the edge. We got to bring them back a little bit with how hard we're working them. So that's why having exceptional therapists as part of the team to get guys back is, and I think everybody on this call would agree, is makes us better at taking care of these athletes.
Hey, Chris, can I say one thing about that? So, we've seen that numerous times. When you see bursal soreness to that degree where he's that inhibited, and then you made such a big change with the injection right away, I'm thinking, what's his mechanics look like? He probably got a little bit of a funky slot. Or in addition to that, what is he doing from a rehab standpoint? You can see his body is a little bit deconditioned, like what Eric was saying. He's a year into this, and he looks kind of like that. He looks pretty soft. So we've got to remotivate this guy, because he might have a little bit of rehab burnout, and just say, hey man, now's the time. You got to get busy. You got to work on your body. You got to work on your core. You got to get stronger, and we have to address your mechanics. So once we start you throwing, you need a motion analysis as well.
A great point, Kevin. I would agree with that. The question that everyone asks at the younger level is my velo going to go up? And my answer is, well, how hard are you going to work? And are you going to optimize mechanics, your strength, your physicality? And are you going to take this as a serious opportunity to get your velo up and not just have a new ligament put in and then rest through the rehab process? So I'm with you. There's a big opportunity. And most of the influence and impact is not from me as the surgeon. It's usually from strength and conditioning and physical therapies to really guide them through it. So, all right, we got just a few more, 11 minutes. I got two more cases I'd like to get through. 19, saw him maybe 2 weeks ago. He's got pain in the anterior shoulder. It's right over the biceps. He rested, took medicine, it's not improving. He did rehab. He did what I think was he's with his college. So I think he's doing reasonable rehab, but it's hard to know. And he gets an MRI scan. Everything's a little bit consistent with a typical thrower. What he's got is good strength, but he's got this dreaded, annoying tenderness in a specific location that is not, I think, well studied in the literature. He's got this. It hurts a lot. That's his spot. It doesn't just hurt a lot. He says, that's what stops me from throwing. Push over his subcoracoid area, his biceps area, and we'll call it subcoracoid or biceps tendonitis. And I don't think we've had a lot of guidance in this area on what this entity is. So let's ask the experts. Joe, what do you think's causing biceps tendonitis, and in fact anybody? Mike Reinhold's on the Reinhold's on also, who's a tremendous expert who's going to speak next session. Anybody got any thoughts on why biceps tendonitis is so common in throwers, and or is it just me who's seeing it?
I'm not going to deny that then that could be pretty sore, but one of the first things I do is I really start to differentiate is that lat attachment, is that subscap attachment versus actual bicipital tendonitis or bicipital groove pain versus the fibers that blend right in there at that same spot on the humerus. Oftentimes we find somebody has like a poor belly press or maybe some weakness with internal rotation or a lat. And this is the new era of pitchers that are pushing their velocity so much. They're getting excessive layback. So they get damage to the internal rotators. And we often see that with anterior shoulder pain. So that may not have been what this particular gentleman has here, but with anterior shoulder pain, I'm almost always going to the internal rotators now.
Hey, Mike, fabulous point. I wanted to target biceps tendonitis as a topic of discussion, but anterior shoulder pain, capsular injury, subscap strain, and lat strain has to be on your diagnosis. If it's deep in the armpit, Eric and I would even start to say, hey, is there a first rib issue or something else with or a coracoid stress injury or something like that. But yes, let's put that on our differential and let's just say that's not the issue. And let's get to the biceps. There's been some thoughts that maybe pec major is squeezing on the biceps and you get biceps tendonitis. And as you know, there's a lot of enthusiasm for biceps tenodesis in patients with slap tears and maybe primary biceps tendonitis. Chris, are you seeing biceps tendonitis, and are you worried about it for his throwing health, or how do you put biceps tendonitis into the mix of managing a high level thrower?
Yeah, I think it's a great question. I think one of the biggest shifts for me in the last few years has been sort of no longer thinking about the biceps in isolation and the superior labrum or slap tear in isolation, and recognizing that it's really a biceps labral complex, and you can get pathology anywhere along that complex. And obviously, what you're showing us here, the labrum looked clean on the MRI. His pain is really over the tendon, so it seems to be more of an isolated tendinopathy to the biceps tendon. As we know, the biceps is a pretty dynamic structure, at least during the throwing motion, and what happens to the glenohumeral joint during that. So yeah, we absolutely see that. It's tough to treat. We know that surgery for the biceps does not have outcomes that we like in throwers. Same thing for slap tears. And so this is one obviously where we try to do everything we can to exhaust non-operative treatment. And I've
Well, along those lines, Chris, what would you do for him right now? He wants to pitch in the spring. I saw this kid last week.
So I think a great place to start is with a diagnostic and therapeutic injection, which is typically helpful to that'll help you tell you if you have the right diagnosis, number one, and then second, hopefully give you some relief so you can start the rehab process.
Okay, Chris was not privileged to this case, but he said inject him, and I probably was reading his mind. So we went ahead and inject him. Do you use ultrasound? Do you do it yourself, or do you send it out?
These are all, there's too much at stake to miss. So these are all ultrasound guided for us.
Do you do it yourself?
I don't know. We have partners in our clinic that just do this.
Come on, get the ultrasound, do it yourself. It's not that hard. What are you going to do? Have him come back? He came from college to come visit you. By the way, I do retroversion assessments in the office, and Frank Alexander, my physician extender athletic trainer, he does it. Use the ultrasound. You can check retroversion. You get information. We have ultrasound in our office, so it is convenient. And this happens to be not a hard injection. You can localize the bicipital groove and get the fluid in. And so we'll see what happens. I think the point of that case is I I see a fair amount of biceps tendonitis, and I know this is a complicated situation. Maybe there's some anterior pec major that needs some work on, and we'll work on it. But I have all the places that I find easy to inject. You inject the sheath, and it actually gets into the intra-articular space. And oftentimes, they're better like that. And if they're not, we'll send them for an MRI scan, and we'll do something a little more aggressive. So any other comments before I jump to the next case? We have 5 more minutes for the next case.
Yeah, Dr. Ahmad, this is Kevin. Yeah, for me, I'm not a huge bicep guy, so I don't really jump on it quite aggressively as everyone else. So for me, the ones that we see are usually females, softball players, swimmers, volleyball players, and some baseball. But unless it's incarcerated or there's some type of weird impingement going on, for me, I always think of dynamic stabilization, that the biceps is working overtime with this anterior shoulder pain. So for me, it's dynamic stabilization. It's working on scapular positioning. It's shockwave therapy to the biceps, laser, and address their biomechanics. Because if they're opening up, if their arm is lagging behind, like Dr. Job taught us with hyperangulation, you're going to overstress the anterior structures your biceps is trying to keep the humeral head in place. So those are the things I think about conservatively as far as non-op.
I agree with you, Kevin. He got biceps tendonitis for a reason, and there's a way to solve that reason, which is with everything you just mentioned. And but sometimes it's annoying. I mean, these guys are hurting right there, and I do think the injection, while it's may seem aggressive with cortisone, et cetera, I think it's a pretty reasonable approach. And I probably do 50 biceps injections a year, probably more. But, all right, let's move to the next case. And this is you mentioned softball. So but just because I saw this patient last week, and as I mentioned, I want to do it in real time. And softball is an interesting sport, and I think there's some analogies to baseball. But I know this young athlete for many years. She came to me with a failed ACL and underwent a revision and got back, and softball means everything to her, and she's at the collegiate level. And then she's got shoulder pain, a weak rotator cuff, and I'm just going to show you some pictures. This is her static position. She's right-handed. We're obviously looking at her from the back for a reason. And now we just say, squeeze your hips. I usually say like you're angry, squeeze your hips. And then she just tries to forward elevate, and she stops just forward elevating because it doesn't feel good and it's hurting. Mike, what do you got here so far?
So the first thing that jumped out on me is she has huge upper trap hypertrophy, which is a little odd for someone, in an overhead sport like that. You can see her upper traps are really toned in that position, which could be really going to mess up with her ability to have that full interaction of upward rotation and protraction. So you see that little winging on the inferior angle of that right scapula there. I mean, it sure looks like she's probably going to have some weakness of those upward rotators, but I'm also looking at that hyperactivity and maybe an imbalance of upper lower trap serratus ratios.
Yeah, good points. AJ, what do you see? Are you seeing anything else on there?
No, just the pronounced medial inferior border winging, which leads very similar to what Mike was thinking in terms of serratus and lower trap, upper trap ratios for sure.
Okay, she's already.
T-spine seems hypomobile to me too. I'd take a look at her mid-thoracic spine.
What does that mean, Kevin? Take a look at it.
Well, it means you have
for
to
mobility, or
yeah, you have to take a look at thoracic mobility in a couple different ways, but I would look at it passively. But anyone that's concave like that, like you're seeing between, some of that could be picture distortion from the scapulas, but she's pretty flat there.
Yeah. Eric, are you still on?
Yeah, I'm listening. I mean, definitely what Mike talked about, you get someone who's got that raging anterior tilt and their only option is to elevate instead of getting that true upward rotation. The one thing, especially in light of that picture you just cut away from, is it's pretty raging on the right side compared to the left. So I'd want to look at how she reaches overhead. Like, are we talking about potentially like a long thoracic nerve person or something along those lines too?
I'm with you. There's scapular dyskinesis, and there's things that are falling just a little bit outside of that bell curve. She's having difficulty lifting her arm up. much less throwing. So I did a scapular assist test on her, which I should have taken some video. I just saw it the other day. And I took these photos mostly to document she was going to change her posture in her exam. But with scapular assist, I reached under her arm, and then I put one hand on her scapula, one hand on her sternum, and pushed her scapula against her thorax. And she lifted her arm up and said, my shoulder hasn't felt this good in a long time, with just manual stabilization of her scapula. So, in fact, we did send her for a ENG nerve conduction study to see if there's long thoracic nerve dysfunction, and maybe there's more etiology to her serratus that's not working. And whether it's positive or negative, I don't know if that's going to have a big impact because we still got to get this scapula working. So, how would you approach this athlete? Is there is there specific maneuvers when it's this bad? Does she need a special brace? Does she need a scapular assist device? Are there specific exercises? This is for the whole panel. Anybody have any great ideas or things they use in their clinic? Please comment.
I'd like to see how she looks when you kind of load it a little bit. Maybe use some long axis compression just to see how her scapula reacts to that. I don't know if I'd put her into a straight push-up position right away, but I'd put her arms against the wall and just to see how the scapula would react in that position. I'd probably do some long axis compression to try to get her to push back into me, kind of teach her how to fire that serratus a little bit. I think looking at, a cat camel to see if she can, have some thoracic kyphosis and see if she can get into those positions to maybe engage her a little bit where she doesn't have to be in full weight bearing. Might be some areas to start.
I think also you need to look at her muscle ratios throughout. So for me, it'd be handheld dynamometry, looking at elevation, depression, protraction, retraction, see where her deficiencies lie. I'd also take a look at, how weak is she in her posterior cuff. To me, it's weird that her right shoulder is higher than her left. She's a thrower. She's right-handed dominant, you said. So that's a little bit peculiar to me. Like Mike's point, I think is excellent with the upper trap. She's really upper trap dominant. The other thing I would do is probably KT taper initially, see if that makes any difference, similar to what you did, Dr. Ahmad, for stabilization. But I'd probably go to a postural shirt when she's walking around doing things, just to decrease and cue her, and then work toward scapular neuromuscular exercises, not necessarily laying on your stomach and just slinging, but probably some closed chain, neuromuscular exercise, a lot of manuals.
Okay, great.
Sometimes too, sometimes I've found that sometimes these people just don't know how to use their scapula well, and they've just been poorly patterning how they elevate their arm. And, again, maybe that's the upper trap hypertrophy versus some of the other issues. Some of it's just some neuromuscular re-education and teaching them how to do it, some pattern assist movements to get that scapular moving again. And then she's an athlete. I mean, if she doesn't have a nerve issue with long thoracic, then, theoretically she might be able to make a quick rebound if we just teach her how to move well and give her the right cues during some of her exercises.
That all makes sense to me. This is one of the most dramatic presentations of a neuromuscular problem that could be as simple as an education or posturing or something. So this is this is something that could save her season with some good quality rehab and good quality education. So while it looks really terrible, I think there's an opportunity to correct this. I will say, I've seen this corrected many times, but I do have one baseball player who I did a split pec major transfer on that just could not do it and now plays recreational baseball. And but surgery for this is not a great option because it's a muscle transfer. It's just not a great option, especially for an elite athlete. So really need to exhaust all options.